Hi, everybody. This is Dr. Jay Greenstein, founder and CEO of Sport and Spine Rehab. I am coming to you live from Washington, D.C. Today, we have a fantastic guest, Dr. Bruce Kehr, psychiatrist and president of Potomac Psychiatry. He spent a number of years working with patients who have sustained traumatic brain injuries, and he treats them in order to feel and function better. And he's also served as an expert witness in many cases related to traumatic brain injury. So Bruce, great to have you with us, my friend.
Oh, thanks so much, Jay. Thanks for inviting me.
So I think it would be appropriate today to start out and just talk about the definition of a traumatic brain injury. So can you tell the listeners and the viewers out there what traumatic brain injury actually is?
Sure, Jay. Well, there are actually three different types of traumatic brain injury. The first is when there's a penetrating injury, when something actually goes through the skull into the brain. The second is called a closed head injury, when the head strikes something solid, but the skull remains intact. And the third is what's called an acceleration-deceleration injury, classic example being whiplash, when you don't actually have to strike the head, but you can have damage as well. And classically, in any of these three injuries, is a disruption of critical brain functions necessary for our day-to-day life.
That's really helpful, and it's interesting that you mentioned whiplash. We see those patients in our practices, but what we also see are a lot of athletes, and they sustain the second and third type of concussion very, very commonly. In fact, many times it's just that acceleration, deceleration type injury where the head doesn't strike any part of someone else's body or doesn't strike the ground, and yet these patients sustain a concussion. So that's great feedback. Can you tell us really what the neuropsychological impact is of these types of injuries?
Certainly. And just to build a little bit, Jay, upon what you're saying before, inside our brains, there are 200 billion neurons or nerve cells. Each neuron can connect to up to 200,000 other cells. So we can have 40,000 trillion connections. And these cells fire up to 50 times a second. There's an awful lot going on up there. So in the context of a brain injury, cells can be disrupted, circuits can be disrupted, connections can be disrupted, even in a whiplash injury. And so when these cells and circuits are disrupted, the typical kinds of problems that develop have to do with executive functioning, like attention, concentration, working memory, the ability to store and retrieve information. The speed of information processing slows down. So we have those kinds of cognitive symptoms. We have emotional symptoms. That can be anxiety. It can be depression. It can be what we call emotional lability, where the moods go up and down.
Sure.
There can be irritability, temper outbursts. There are a lot of emotional symptoms that can come along with it. There can be behaviors. Sometimes people even have personality changes where they're more aggressive or assertive. And then finally, there can be physical symptoms, a lot of what you deal with day in and day out, not uncommonly pain, headache, disequilibrium,
yes,
vertigo.
Balance issues is a really big one, absolutely. Yeah, it's really interesting that you mentioned these whiplash type cases, because we are starting to actually, through our clinical research foundation, we're starting to identify these subclinical cases using what's called the graded symptom checklist, which is a standardized outcome assessment tool. And we're using this form to evaluate these patients that may not even realize that they've actually sustained a concussion. How common is that in your practice?
I think that's quite common. What we see is it takes a while, sometimes weeks or even months, for it to sink in for the person how they're different, how they've changed. And what's interesting is even sometimes neuropsychological testing, very sophisticated testing, doesn't pick up on memory problems that people are complaining of. And recent data shows that certain kinds of functional MRI tests, like fMRI, MRS, or diffusion tensor imaging, these are what we call functional MRI tests. These can pick up very subtle problems in brain function that even neuropsychological testing can't.
It's a great point. I was at the Youth Sports Safety Alliance Summit last year, and there was a presenter from one of the universities there discussing the latest research in functional MRI. And what they found is that even though the patient had really recovered in terms of their symptoms and their functional ability, some of the testing they do, balance testing, et cetera, there were still changes in the brain. So yeah, clinically they look great, but yet the brain had not completely healed.
Correct.
Yeah, so those tests can be really important. So let's talk about treatment, Bruce. What's the latest and greatest evidence say about the kinds of treatments that your clinicians are providing to these types of patients?
Sure. Well, what we take is what's called a symptom-based approach. There's no single treatment or type of regimen that works for a population of people with traumatic brain injury. We have to take each person as an individual. So let's look at the different symptom clusters, what could be helpful. If we start with the cognitive symptoms, problems with sustaining attention, lower information processing speed, executive functioning problems, these not uncommonly respond to neurostimulants. The mixed amphetamine salts like Adderall, Vyvanse, the methylphenidate group like Ritalin, Concerta, Focalin can be helpful. Provigil or Nuvigil can sometimes be helpful. Simitrel, amantadine can sometimes be helpful. What these have in common is boosting activity of dopamine and norepinephrine in the frontal lobes to help with that information processing executive function. Then when it comes to the emotional and behavioral symptoms, options range from antidepressants. Some antidepressants not only work on depression and anxiety, but they also improve the activity of acetylcholine and dopamine and norepinephrine, so they can also improve memory function and cognitive function. One such medication is called Trintellix. And then if there's a lot of labile emotions, up and down mood swings, anger up, or sometimes the mood stabilizers, anticonvulsants can be helpful there.
That's incredibly helpful. And what I love about your approach in your practice is that it's very patient-centered. It's not a one-size-fits-all kind of treatment plan. It's the evaluation, the appropriate diagnosis, and then the appropriate intervention. And it's great that we can do things like coordinate care where we can handle the physical and functional musculoskeletal elements, and you all can also handle actually the chemical changes that are happening in the brain through the appropriate use of medication. So that's great to hear. Are there any closing statements, Bruce, that you would like to provide to our audience, someone who may have sustained a concussion or has post-concussive syndrome, patients who are not resolving? What would you suggest for those
Sure.
folks?
Well, I think what's most important is to feel hopeful. Within 3 months following a concussion, 50% of people have a full recovery. Within 6 months, 80 to 90% have a full recovery. Recent data suggests that around day 14, it's okay to begin some light physical exercise because actually that boosts neurotransmitters and neuroprotective chemicals that actually help the brain heal. For the remaining 10% to 20% who don't recover after 6 months, there are a variety of ways to help, ranging from cognitive stimulation programs to ongoing medication management, to helping with different lifestyle modification strategies. And sometimes now we're seeing even a role for certain supplements that can help promote the protection and growth of new brain cells and new connections within the brain. So it's important to remain hopeful.
That's great. That's great information. Thank you so much. And Bruce, if somebody needs to get a hold of you or your practice, can you give them some information? I know you write a fantastic evidence-based blog. Can you provide that information for our audience, please?
Sure. So to learn more about traumatic brain injury, depression, anxiety, if the viewer goes to drbrucekehr.com, it's drbrucekehr.com/blog. There's a search engine, just put in your keywords and search. And for our practice, it's PotomacPsychiatry.com.
Fantastic, Bruce. Hey, thank you so much for being with us today. We really enjoyed this. It was an awesome, awesome discussion, and we will be seeing you again soon.
Thank you so much, Jay. Take care.
Have a great day. Bye.
All right, bye-bye.